the various metrics. I think those are the key layers, but let's learn via the actual examples. So, gentlemen, let's get to a couple of questions to begin. Um, I think we should first of all start, one second, let me change my screen. Okay, I stopped sharing and we can open this up. So question number one, how did you, and to this date, how do you assess AI solutions? How do you start? How do you choose which use cases from which vendor? How do you take into account implementation effort? There are various options of how to do so, but also in general, what's the magnitude? Meaning, is the use case worth the cost? And I don't necessarily mean the financial cost, but the effort of implementing. And then once you do so, how do you evaluate whether it's effective, what the adoption's like, whether it's valuable, etc. So I'd love to hear, let's start with you, Dr. Sharma. I'd love to hear your perspective on this. And then in particular, what is, from your perspective, the potential role of a platform in that process?
That's a great question. And thank you again for having the time for us to have a great conversation about all of these exciting topics. So I'd like to give a little bit of history of ADOC and Jefferson Einstein. So we actually started way back in 2017, 2018, when ADOC was just a small booth in the basement of RSNA, and they were pitching a new solutions that could help AI detection in the world of radiology. Very exciting, very novel, but they ultimately were looking for partners to help prove the theory that they had, that AI can help radiology. So when we first started, we were very much in the academic sandbox, just testing these tools for their potential, their accuracy, and then frankly, ultimately deciding whether they would be worth scaling. So it was very intentional and measured at that time. So at the start, we weren't platform thinking, but we were obviously growing into it. And I think what made that transition seamless is that we grew alongside ADOC. ADOC didn't come in as just a bolt-on isolated tool. It really focused on integrating into our systems and then evolving into a true enterprise layer. And I think eventually now, as we grew out more of their solutions, for context, we did start with their ICHPE solutions, but now we offer their entire suite of solutions. And it made a lot of sense for them to really think about systemically, how do we approach all these different algorithms? How do we congregate the outputs of these solutions and make it very seamless for the radiologist to digest it? And that naturally translated into the widget and now the iOS platform that you guys have. So really, it's not just about thinking about narrow use cases. It's really about connecting this fabric of AI across all the different clinical departments that could be touched by it. And that integration layer that you guys focused on allowed you guys to very easily move beyond radiology, ultimately, allowing us to touch the other subspecialties that require and need this information so that they can prioritize and mobilize the units that are needed in order to take action and improve patient care ultimately.
Thank you, Dr. Sharma. Very insightful.
Yeah.
Dr. Hayat Bincourt, what's your perspective on this topic?
Yeah, it's interesting because our perspective was somewhat complementary and from a slightly different standpoint than Jefferson Einstein. First of all, I met you and ADOC some 8 years ago in São Paulo when we both were young too. But I joined my institution, it's going to be 5 years ago now. And we too had here that culture of co-development and industry academic partnerships with up-and-coming AI startups and some very successful small individual engagements. But by the time we got in touch with ADOC here, ADOC was already at another level, was not anymore at that same level of individual engagement. So we did not get that first wave that Jefferson got. But still, we learned about the successes of bringing AI collaborations to clinical practice. However, because those were individual engagements, they were limited to some niche scenarios. And it was very hard at that time to measure the net benefits and the system-wide benefits of each individual use case that we had incorporated. So it was a very intentional and strategic move from our leadership and other experts in the field of AI in my department that we had to step up to an all-inclusive, across-the-board platform that would touch upon every corner of our department. And in my capacity as vice chair of innovation, I also had the task of disseminating the culture of innovation and AI across the department. So having it only made sense to have a platform that would be tangible to every radiologist in the department all at once and would not be restricted to one or two use cases. So instead of developing, like Dr. Sharma said, from the PE standpoint, and then scaling that up and rolling out other use cases, we decided to do everything all at once. And like from day one, it was all turned off. Actually, not from day one, it was scaled, but from day one, the whole department had access to the same tools. And I would say that the benefits that we collected from that was that suddenly every radiologist in the department was AI literate and was able to discuss those complex concepts of AI that people think are only for a handful. Now everybody can discuss the simple things about AI in my department. The other point that played in our decision, the strategic decision in adopting a platform, is that we also wanted, as radiology leaders and as leaders in a health system, right, to take a content ownership of the AI domain in radiology, because it is very common that vendors and startups, they appeal to other departments, other specialties, and say, hey, do you want your reports faster? Then you go and you buy this from us, and then you push your radiologist to do it without them knowing how does it affect the whole workflow, the value generation chain, and all that. So since we already had that experience up front in successfully deploying AI applications, that was the moment that we said, yes, we also need to plant the flag and say, hey, we need something that goes 360 around radiology to different use cases, interacting with different departments, different specialties, different lines of care, that would tell them, hey, radiology is about radiology first, and we understand what's inside the box. So it was also a very strategic move that was behind our decision to adopt a platform.
Fascinating. We'll get back to the topic of basically the decisions related to cross-specialty use cases. And basically it's the question of, is this radiology AI or is this enterprise imaging AI? And what does it mean, enterprise imaging AI? Who decides how, and what is the role of radiologist in leading this change? So I think that's a fascinating topic. And as use cases expand and sometimes touch various specialties, I think it's a very important topic to be intentional about and to lead versus be reactive to. Before we get into that, let's call it advanced topic. Here's somewhat of a, on one hand, basic question. On the other hand, I'm sure many deployments have stumbled and some might have failed, related to the basics. So let's take you, Dr. Kite Bincourt. You know, UH is a very large and diverse health system. You said something that almost sounds so simple, right? Like, we deployed a batch of AI solutions across all our hospitals, all our radiologists, and they all became literate quite quickly. But from a technical perspective, we know in healthcare IT that things are quite complex. You know, certain AI solutions require going scanner by scanner, server by server. It's definitely not a flip of a switch. But with the platform, what was that experience like? Was it actually relatively straightforward to expand various use cases and solutions across your whole enterprise? Or what was it like from the IT perspective of this, as far as you know?
Fascinating question, and this could be a webinar in its own, right? But
Yeah.
I have many, and when something is successful, it's always easier to look back and justify things, right? But we try to identify some of the factors that contributed to such a, and I would say, very successful rollout of an AI platform in our institution. I would say one thing, and all the credit goes to our radiology informatics team and department, and their connections with the corporate informatics. I believe that it was a very beneficial halo effect that we got, like a vacuum or a momentum that we got, because we had just been through a major EHR turnaround. So we changed our EHR vendors. and the whole system, everyone, every employee, every doctor, every department, everybody was affected by this rollout of the new EHR that we used. And there was a whole strategy, a whole operation in place from informatics to educate people, to do change management, to have people in person and at the bedside and at the radiology departments and everywhere to help people navigate that change. And there were so many lessons learned in operating this major change that has been in plan for 5 years in my institution, that once we decided to implement the platform, then 4 or 5 months later, we were all in the same mindset, and it was very natural that we knew some of the steps to take. And adding to that, also that, and that's a compliment to the ADOC team. You have a very well-established playbook of success in implementation, some steps to be taken, and the rolling out of which solution to implement when and how's the best way to make sure that people are educated. That was a perfect marriage between our team and the lessons they learned and their expertise to the expertise that you brought. And I would probably wrap this up with the recognition to some great colleagues that we have here in our department that are all huddled together and interestingly from different subspecialties in radiology, so representation from cardiothoracic, neuro, body, and others that are interested in driving the AI agenda. So we have like this informal council of AI elders here that were also part of the early adopters and early promoters and disseminators. So I think those are some of the aspects that we had in mind that contributed to the success of this implementation.
Thank you very much. And I completely...
And one other point, sorry, that was also missed. When you talk about a platform, right? I don't think that every platform is like one another. I think there is a critical element in the ADOC platform, and by no means this is no advertisement. It's just a recognition of a point that is very important to consider, that the AI orchestrator that is present as a layer in the platform, and that relieves that need, like you're saying, of setting up each individual server modality, a title to each interest, to each scan, each exam,
protocol,
to an address.
study description.
Right? Exactly. So you say that, and you're completely right. It's a huge effort to implement a digital solution to information systems, but once you bring another AI layer in the mix that helps you figure out stuff, right? I think this is another element that contributes to a successful implementation of a platform.
Thank you.
Well said. That was great. Yeah, I love to chime in there because I feel like Leo brought in a lot of great points about having a good partnership, and the point he just made about the fact that ADOC has tried and failed a lot, from the fact that when deploying in such a heterogeneous situation, there are a ton of scanners, there are different types of radiologists and workflows that have to make sense, and ADOC's history of knowing and dealing with so many different scenarios, I think, is where they've had success in being effective immediately. It reminds me of the metadata drift research that we published just a few years ago, where in essence, they originally used a traditional rules-based method of capturing relevant exams for processing, and they eventually developed an AI orchestrated platform where we proved that we had a boost of about 20% in capturing appropriate use cases, no longer requiring on, say, CT pulmonary embolism to be included in the rules, but rather, hey, there are lungs and there's opacified pulmonary arteries, this should get processed. And it's that common sense that you end up realizing by doing that this is the way you actually capture patients, and less patients fall through the cracks ultimately.
That's a great point. And I think it's a perfect segue to one of our topics, basically incidental findings. So let's connect that to orchestration. And we specifically use AI-based orchestration because we, over time, essentially out of necessity, back when we were naive and we thought it would be simply a matter of PACS forwarding rules. And over time, we saw that there are endless changes in scanners protocols. And as we address scan types that have various types of studies, you basically can no longer chase all of these terms. And there's also variability between technologists, et cetera, et cetera. So we had to develop it out of necessity. Once we stepped out of a niche scan type and one hospital, and we went kind of enterprise-wide to various types of scans and algorithms. But the most extreme example for that is incidental findings. Because even if you have, which isn't really the reality, perfectly standardized, a limited number of scan types, which isn't the reality, but even if you had that, incidental findings introduces also an aspect of image-based orchestration that's required. Because let's take the example of a pelvis and abdomen CT exam with contrast. Say it was easy to understand what that scan is. Then there's the question of, in the edge of the film, how much of the lungs are in there? What part of the base of the lungs? And should you run pulmonology and pulmonary oriented algorithms on that or not? So for that, you don't just solve what is the scan type, but you also need to kind of navigate within the scan and understand the anatomies and the contrast timing, et cetera, to activate various types of incidental AI algorithms. So Dr. Sharma, I know you guys have performed a clinical study related to PE, both in terms of the higher risk PE and cross specialty workflows, which I'd love for you to share about, but also with your experience with incidental algorithms, for example, incidental PE.
Yeah,
What
absolutely.
does such
So
orchestration enable? What are some anecdotal examples? And then how does that go all the way from incidental segmental PEs to higher risk PERT related use cases?
yeah, exactly. And yeah, I'd love to talk about our PERT team and how that really has been bolstered in these last couple of years. And ultimately, it's about the enterprise impact, right? Crossing the chasm and embedding these tools into multidisciplinary workflows. Because what happens after the alert? You want to figure out and make sure it reaches the right team, it leads to some timely action, and ultimately improves care. So our PERT team really benefited from the integration of the mobile alert system. In essence, we are able to flag potential cases that have a positive PE, and the interventionalists, our interventional radiologists, are able to see within the app whether this is a case that needs to bring me in, say, in overnight evening hours, or I can start picking up the phone and alerting even the ED before they even know about it that, yes, this patient is coming to our department for some intervention. So we were able to start comparing and then measuring the exam to needle time. And ultimately, we were able to prove that, yes, there was a reduction in amount of time to getting that patient onto the table. Say 20, 30 minutes is on average of what it ended up being. That's a half hour, and that's people's time that is now in a greater odds of success having a positive outcome rather than a negative one. And that ultimately, that synergy, that's the game changer, right? Radiology is talking to the ED and it's talking to the ICU departments. Everyone's synchronized on one platform and making decisions together. And with that, another measure that we were able to quantify is the number of PERT activations. So after we had deployment, we had a metric that showed that we doubled the number of interventions that we were doing. And that's not a metric, that are patients' lives. There are patients that are being treated faster, more frequently, and with more clear communication among the departments. And so that's something I'm very excited about. And the point that you had brought up that I'd love to talk about is the concept of incidental findings. I think population health AI is getting really a lot of buzz and traction as of late. And I think this is an opportunity where platforms orchestration and workflow capabilities, that's where it really shines. Because ultimately, we are all overburdened and overworked, and we're burnt out. And these incidental findings, they don't really sit neatly in a single department's workflow. They can be easy to miss, they can fall between the cracks, and unless you've got a connected infrastructure, things can very easily get lost in the way. So incidental coronary artery calcifications is something that we started focusing on first. Obviously, this is a huge public health opportunity. There are ways in which these findings are remarked on reports, but they get buried. No one acts upon them, even though they've already been proven to be predictive of cardiovascular risk. So in tandem with our cardiology department, ADOC has bridged this connection where we can now create a platform for our cardiologists to then see the patients that we have flagged with moderate to severe coronary artery calcification and gets populated onto a work list for them to then determine whether this patient is eligible for referral. But on top of that, it's about layering an NLP process, right? No department has a time or bandwidth to start scouring whether this patient is eligible or requires a cardiology referral or has been seen before, is already being medically managed. That's all information available to us in the EMR. And it doesn't make a lot of sense to scour that information automatically and then only filter the patient list to be those that require a referral and who need more urgent attention. So we've been doing that for the last, 6 to 12 months now, and we've been able to capture through the number of patients that we've been able to touch is that some of these patients then go on to have some sort of intervention, whether a CABG or a catheterization. Just being able to see and visualize and even capture that information to then showcase to the C-suite that, hey, these are patients that are being touched, really resonates with the department and the C-suite.
I like how you mentioned that point, and I want to connect it to a broader topic. Um, Essentially moving from imaging only to imaging and EMR, multimodal, just like a physician. So I think phase one of AI was to do imaging AI effectively, which means both the algorithms and all of the platform-oriented aspects like orchestration and reach accuracy rates that are high enough to help attendings. So basically, subspecialized radiologists. It's not easy to reach those rates. Um, Phase two is connecting that with clinical data to customize workflows, like, for example, stratifying the different types of PE, both from an imaging perspective, meaning is there a PE? Is it central PE? Is there RVLV? How high is it? So that's the imaging side, but also the EMR side. What are the vitals like? What are the labs? What's the troponin, et cetera? Because downstream, other physicians, that's part of what helps them determine whether to escalate and who to activate. So that's phase two. And you gave such examples also with incidental coronary artery calcification, which it's not just like what is their CAC and what's the severity level, but also is the patient already on stents? Are they already seen by cardiology? Yes, no, et cetera, to avoid overwhelming. So similar concept. And phase three, that at least on the ADOC side we've entered, and it's an exciting one, is when you process the scan, also connecting that with the EMR data for the patient. So instead of just looking for nodule blindly, like maybe a teleradiologist would that doesn't have EMR data, also affecting your sensitivity by does the patient have cancer? Has the patient been smoking, etc. Just like a human physician leverages those insights. So that's kind of the current phase. It's an exciting one, and it will lead to more tailored results and more accurate results based on the circumstances. So that's just a side topic that I think it's quite exciting to see this evolution. Dr. Kayat Bincourt, if you don't mind sharing your perspective on because we spoke about PE, but in particular, high risk PERT use cases. What's your view? And I know you guys implemented quite an interesting diagnostic radiology workflow that includes the work list, and a very seamless workflow from that perspective. So if we take the example of an incidental PE of, say, an outpatient, so like a patient who got an outpatient scan for, say, cancer-related reasons, and we know, about 2% of them have incidental PEs. And presumably, especially currently with radiology shortage and the increasing number of scans, turnaround times, it's difficult to reach, especially for outpatient, low turnaround times. And most of
So,
them are acute,
no,
so
go ahead.
don't need to necessarily be read super closely. What's the diagnostic radiology workflow perspective on this? How have you set up your workflow in a way that's seamless for your radiologist to truly realize the value of such AI applications?
So it's interesting, this question, also comparing experiences from different institutions and some cultural choices too, right? So in my institution, what I perceive is that it prevails a culture of trying to standardize delivery of care, communication channels, and processes to prevent variations from individual solutions or few scenarios. So when we rolled out the platform, and it came with the care delivery pathways too. There was a discussion if we would utilize the phone app that ADOC provides, or if we would try to route it to our more common communication method. So before we brought up the AI platform, we already had multiple tracks of different incidental findings that were followed and that were managed already. And it usually involves, and I'm now taking AI out of the equation, right? So because there was already a preferred way to manage all of the incidental findings that are coming from different modalities and everything related to radiology, it was also preferred that we incorporate the incidental findings that are generated from AI doc or other AI applications into this same workflow. And even though we may not be leveraging the full capacity of what your applications on other applications can provide, ultimately we end up choosing a standardization of delivery of care. And our SLAs for PE, for example, are within 30 minutes and at plus more than 90-something% of the time. So it's not the reading of the exam that is taking most of the time in the communication.
So I have a comment there. So first of all, I completely agree with the approach that AI and workflows are not one size fits all. There are lots of considerations, and I believe that as an AI platform, our role is to be modular and do our part based on what makes sense and what the preferences are of each health system. In some cases, we're Intel inside, we're the intelligence behind the scenes, and we augment existing workflows. In other cases where it's needed or it makes sense, we could also be an interface, like a mobile app or a radiology co-pilot, et cetera, et cetera. So I think that makes a lot of sense, and I think that's an important consideration for the audience as you consider platforms and deployment models. And as you tie it to different types of use cases, there's a lot of sophistication. So I suggest kind of talking to peers, talking to the AI platform vendor, et cetera, to figure out, to understand the options and what makes sense for you, and ideally be able to customize that. I have a question, Dr. Bincourt, on specifically the diagnostic radiologist workflow, because some of what you described is downstream to radiology, right?
Yeah.
Radiologists did the report, there's a macro, and now we're talking about navigators and other clinicians down the line, et cetera. But what do you think are some of the basic requirements from the radiologist perspective, the diagnostic radiologist perspective of the workflow?
So I think it ties in very well with your comments that followed up to my response, and also to a general statement that I think would be very useful to all the C-suite and decisors here, is that AI is only as good as what you make of it and how you fit it in the value chain. So if you can, as much as you can, avoid the buzz of AI as snake oil or as solution to all problems, because you throw it there and you wait for AI to do its thing, and you understand that it's just one step or multiple steps along a value chain and a workflow that you have to know and control and understand and measure within your own institution and within your own resources. I think that's how you're going to optimize your use of AI, right? So when you bring in a platform, it will only be as good as your understanding on how to fit their outputs or their communications to the next item in the care delivery chain. So in our case, we found out that, well, the way that you present your platform with having a widget that is responsive and reactive to each exam that is open is the usual go-to, with additional capabilities of customizing the types of notifications that people are going to get and so on. But our informatics division was also very experienced and capable in extracting some of the messages that were coming from the ADOC solution to our PAC system and our work list, and then translating that into a column that can be added to our work list and then allow for us to also prioritize the cases via PAC. And they prefer to use a workflow-driven prioritization or PACS-driven prioritization. Others prefer to have the interactivity of the widget. So I think that the department was already mature enough in understanding how to operate different AI applications that we had in the past, in incorporating that expertise into different ways to cater to different preferences in working. So in my personal case, when I'm on call, I usually cover only one site. So my list is almost never fully populated. It's always like one exam comes, I read it, I sign it off, and then the next one. So there's not much of a need for me to prioritize a work list. So I use it more as a safety net and as a screening tool for patients with trauma and IPAN scans. And I have all the conditions that the patient has or doesn't have. But then other colleagues, they are covering pools of lists and big lists that are always populated and that are only, as we say in Portuguese, trying to dry the ice, because they keep on refilling. And then those colleagues, they prefer to use the prioritization approach, and then they can click on, and there are different columns for AI solutions that we have that they can prioritize accordingly, and they can read those first too. So I mean, in the radiology part of the workflow, I think we did a very good job in customizing and in catering to different tastes.
That's fascinating. I think essentially what we captured there is not only being modular at the health system level, there's modularity at potentially the hospital level, at
Correct.
the subspecialist level, at the shift level, at the user, at the personal preferences of each user level.
Right.
Uh, so I think the ideal is being able to tailor that without custom implementation and custom development. So I think essentially it's the recognition that healthcare is complex, and this is the opposite of one size fits all.
Correct. And one conclusion on this, and understanding that it's so highly customizable on every possible level. It's like a Formula One car, right? If you give it in my hands, people are going to crash because I don't know the single thing about Formula One. But if you have a Formula One car that belongs to radiology, you better have radiology people in the cockpit, and understanding how to turn like the nuts and bolts there, because there's so much customization and so much impact of different choices along the way that you got to know what you're dealing with.
That's a great point, and I'd like to chime in because I think it's a really important point about how do you determine success of the AI that you implement and deploy, right? Ultimately, a lot of the points that Leo is bringing up includes change management. It includes leadership within the subspecialty to help guide and nurture and motivate colleagues to begin using the product as they see fit. And ultimately, it's about learning about how you can measure the impact. And I think he described a situation where he's like, oh, I only use it, ad hoc in a widget use case, but then my colleague uses it in a way to monitor a bunch of different lists. And ultimately, it requires someone at the grassroots level to really intimately know what the workflow is to make sure that the product is optimized for their colleagues. And I think Leah would attest to this, is that ultimately radiology and radiologists have had the most experience of trying and failing AI. And ultimately, if the C-suite is thinking about, oh, how do I ensure or at least increase the odds of having success in securing or purchasing AI, I would look to your radiology department, because ultimately they've done this a lot and they know what's stuck to the wall and what didn't. And they can help nurture and guide your decisions to help making sure that whatever AI you get ends up being something that's well worth your time and energy and cost ultimately.
Thank you very much. That was fascinating, and I completely agree. I think, Dr. Sharma, you essentially took us to the topic of AI governance. So I'd like to ask you a different angle related to AI governance, and that is working with all the stakeholders to bring AI in, to demonstrate its value, to justify expansions. You've experienced that both within kind of Einstein part of Jefferson and then expansions across all of Jefferson. Some tips to the audience on how to run this tricky process.
Yeah. it's a great question, and I will preface it with welcome the growing pains, because ultimately no one has this figured out yet. And as me and Leo are talking, every institution is different. So again, mindsets and culture is very different, and you have to be mindful of that. But governance is becoming another buzzword because ultimately more onus is being put on the hospital systems themselves to determine how can AI be effectively deployed, monitoring for bias, data drift, and ensuring that the patient safety is kept at the forefront. So we've been going through our own process in which we've had our own imaging AI committee locally at Jefferson Einstein, and has also scaled up to the entire enterprise. So Jefferson Einstein was one ecosystem. Well, now we have, gosh, over a dozen different hospitals within our systems. And that means that when looking at AI, you really need to think about something that is agnostic and can work well no matter the hospital system department. But layered on top of it now with the advent of generative AI solutions, now we have an even larger enterprise AI steering committee, which is an umbrella organization now dealing with the entire healthcare system across all different specialties. A lot of demands, a lot of needs, a lot of people that want to start using AI yesterday, but they don't know where to start. So where we are in this process is ultimately, let's gather all of the appropriate stakeholders, legal, IT, C-suite, clinician leaders and champions within each of the departments, and bringing them all to the table. And where we are now is we're ultimately saying, okay, we are at an enterprise level. Let's start putting pen to paper of what is important to us and what we are ensuring that every AI commercially or in-house works within these guidelines. It's important to create these guardrails. Especially, yeah, I would like to highlight just section 1557 of the ACA is important because now it's saying that we as the enterprise healthcare system, we're responsible for ensuring that these AI solutions work well and they don't fall off to the wayside. So it's first and foremost making sure that we actually create the guardrails, but now it's like, okay, how do we now figure out what existing AI solutions we've had across the enterprise, figure out which ones are scalable and which ones aren't, and then of course now monitoring the cost of it all, because there are partnerships and agreements that one hospital may have with one group, but ultimately you have to figure out, can that vendor handle this entire healthcare system? And then can we afford it, or can we trust that they will be able to work with all these different systems? These are all conversations we're having constantly because it requires us to sort of first start at the grassroots level, gather all of the appropriate intakes, see where we are currently at in our AI landscape, and then start funneling them through a more regulated process to figure out what is actually going to be a long-term fit versus ones that will have to eventually sunset.
Perfect. Thank you very much, Dr. Sharma. We have 3 more minutes. So Dr. Kayat Bincourt, I'd love to ask you a quick question, just because I think it's quite an interesting anecdotal example that I've heard from you in the past, and then we'll open it up for questions. So from an AI governance perspective and monitoring, we've kind of been thinking about the lens of how do you collect data, how do you translate that to value, et cetera. And it's always basically robust and aggregate data, etc. But then there are these anecdotal situations. So one type of anecdotal situation is the anecdotal wow moment or you saved the day sort of scenario. But I want to hear the other type of anecdotal situation that ideally never happens, but in reality happens sometimes, which is like downtime that's bigger than AI or ADOC when there's IT related issues that also affect AI and everything else. And all of a sudden, the radiologists don't have this AI software that they're used to. And then getting that kind of anecdotal feedback of like what happens when it's off, which ideally would never happen, but sometimes happens and oftentimes unrelated to the AI software itself. So I think you
Yeah,
have a good story there. I'd love to
it
hear
was a
it.
fun, interesting story that happened 2 weeks ago. I was on call for the big weekend of Memorial Day here, and I noticed on Sunday afternoon that I was not getting inferences. And I tested in different ways. And this is something that I am particularly interested in. So I'm quick to notice that happening, right? So we have an internal chat tool for the PAC system with the RedOps team, and I communicated with them, and they investigate possible outages of things. I asked the residents, and the residents confirm, yeah, it's acting out for a few hours. I don't know what's happening, so they noticed too. And then within 2-3 hours, the system was back again. There was no harm done to our understanding. But the next day, we started getting the emails that the platform sends for non-engagement alerts, which means that reports went out without interaction with the widget when there was some kind of notification. And those non-engagement alerts were a spike of probably 4 or 5 came out about that window of time of 2 or 3 hours that we were left without the service. And when they were usually 1 or 2 a week before and after that. So there was a significant spike of non-engagement alerts during the time. And then whenever there's a non-engagement alert, the physician that signs off the report gets also that notification that gives them the chance to review and addend the report. And one of them, they commented like, wow, this was indeed a miss. It was a minor miss. It was indeed a miss on my end, but and that's what interested me the most. But I and my colleagues from a regional satellite division, we noticed that the AI tool was off for a few hours on that time. And we would like to understand and to have it investigated why it was off. So the fact, and that comes full circle with my initial comment, right? The fact that we had a colleague who is not in the academic division, who is a great clinical radiologist, but not involved with AI directly. And we were not expecting them to be that involved with the use of AI tools, but they noticed on the spot that they were left without that safety net for that amount of time. And that they connected the fact that when the non-engagement alert came to that window of time when there was an outage of AI, to me, that's a wonderful demonstration on how aware people get once they start using AI and not AI like a buzzword, but they start using a platform, they start incorporating that to their workflow through meaningful use, and they're left without. So now we are coming to the spot that we now know when there's an outage of PACS, an outage of the dictation system, but when you can show the awareness on an outage of an AI tool, I mean, that's a successful implementation across your system. We're going to publish on that, by the way.
Wow, interesting. Yeah. It leads to questions of whether you should sometimes turn it off on purpose. Okay, thank you, gentlemen. Let's keep the next 8 minutes for a few questions. One question I see here from the audience is, what kind of resistance, if any, did you face when implementing AI across the enterprise, and how did you overcome it, either of you?
I can start off because I think ultimately when we started, we were still in the trust building phase of AI, right? And I think people ultimately get very defensive about something conceptually, quote unquote, replacing us. And they ultimately are saying, you know what, I would be better off without it than with it. But ultimately, with anything, with any new technology, when we transition from Blackberries to touchscreen smartphones, from gas-powered vehicles, electric vehicles, it requires some nurturing and some confidence building, and then some meaningful data to prove that, yes, it does work well, and 2, you're better off with it than without it. So for us, I think ultimately it required me, especially, that within our biweekly or monthly staff meetings to really highlight impact from these solutions and what could theoretically happen had the tool not been used. So Leo had alluded to it. There are these QA alerts that one can have where we can flag cases perhaps during the overnight telehawk hours where a finding was seen but was not noted within the report. And then I, as the local AI champion, receive that notification, and I can adjudicate whether this is something we agree or disagree with. Well, that just shows examples of where, okay, say a PE was missed on, say, a CT neck exam. That's a patient that potentially was discharged because the exam was indicated for another reason. And that ultimately is an example of where the patient was brought back because they do have positive PE and that patient should get medically managed. I think ultimately highlighting and showcasing examples like that is where the trust building process happens. And I've ultimately accepted that I will never have 100% compliance and usage by everyone. It's just impractical. Some people are very much set in their ways of how they do things, and they've done it for ways for many years. And who am I to come in and start forcing them to augment their workflow? That it's tried and tested, and I've understood and respected that some people will not be willing to make the change. Well, ultimately, it's about nurturing those people in the in between, right? It's the middle 50% that we're trying to tackle and get them to take the leap. And I've had a lot of success, again, sharing data metrics like this with real life examples, with examples of their fellow colleagues to really get them start moving. So it's all about building that trust and momentum.
Thank you, Dr. Sharma. Let's try to get to another question at the very least. We're in early stages of forming an AI governance committee for the health system. How did your institutions decide who should be at the table, especially when balancing the various types of physicians, IT, and other potential administrators? Dr. Kayat Bincourt, given your size, and certain AI applications that are kind of in between specialties. What's your view on that, and in particular, radiology's role in that sort of committee?
I think that I am fortunate to be at an institution that has the maturity and understanding of the centrality of radiology in radiology AI and in AI in general. And also the way that I was brought in here, I was brought also in connections with the innovation vertical of the whole institution. So whenever the topic of AI came up, I was called in to the table at that time. But then as things progressed, especially with now the emergence of large language models and other more sophisticated types of AI in other areas of healthcare, then they decided to imbue it with more governance structure. So currently what we have here is a C-suite level AI committee that is the ultimate regulatory body in the institution. But there is also a clinical AI council and an AI council that involves the clinical team, but is under the C-suite AI council. That is the operative AI council that has the intake of the requests. And the IRB, so the research center, has also an AI core that evaluates research projects that involve the use of AI tools. It is still a work in progress to understand how those instances are going to interact and how can we make it in a more agile way. But there is participation always from C-suite people related to innovation, informatics, and business. And along every instance, we have representation from their peers and their people from their team. And whenever there's a clinical representation, there is always a radiologist there too. And we have also the fortunate to have the very CMIO of my system be a radiologist, our executive vice chair. So I believe that we are very well represented and also very well heard in our institution. One thing that I would add in terms of resistance and also how to drive expertise, I think it has a lot to do with the reputation that the department has achieved with successfully deploying. And those success stories, they end up resonating across the institution. I think it's the same with Avi, Dr. Sharma there. They resonate across the institution and they get you to help drive the agenda from the bottom up on how to adopt AI.
Excellent. Thank you very much. I think with a minute and a half left, it's just worth connecting our conversation to the initial slide. So back when we looked at this just as a diagram with various rows, the AI engine, which essentially means the types of AI solutions, data orchestration, we talked about orchestration quite a bit with various examples, AI monitoring and AI analytics, and then action layer, which is the different types of workflows, whether it's within diagnostic radiology and or across specialties and downstream. So I think it's very important for the audience to recognize that it isn't just a matter of choosing algorithms, but it's actually how they'll be incorporated and how they'll run in the wild to make sure that the AI realizes its value and that different workflows and users can tailor it to personal preferences, to departments, to hospitals, to health systems, etc. So in short, I'd say this challenge is complicated. The platform needs to be quite robust to actually overcome those challenges. I'd like to thank you too. This was a fascinating conversation. Thanks to the audience for joining us. Hopefully, you guys found it insightful. And we're looking forward to our next webinar. Thank you guys. Have a good rest of your day and bye bye.
Thank you.
Thank you. Bye bye.
Thank you.